Welcome back to Anatomiqa. In this session, we will be discussing the details on the front or anterior compartment of leg and dorsum of foot. Both are discussed together since the structures are continuous and with each other in these regions. The learning objective of this session are describe and demonstrate major muscles of anterior compartment of leg with their attachments, nerve supply and actions. Describe and demonstrate the origin, course, relations, branches, termination of anterior tibial artery. Describe and demonstrate the origin, course, relations, branches, termination of dorsalis pedis artery. Describe and demonstrate the origin, course, relations, branches, termination of deep peroneal nerve. And explain anatomical basis of foot drop. Let us discuss in detail the structures in front of leg and dorsum of foot from superficial to deep. The layers from superficial to deep are the cutaneous nerves and veins, supplying skin and superficial fascia, lymphatics, deep fascia, contents including muscles, nerves and vessels. To start with the skin over the front of leg is supplied by the following cutaneous nerves. The lateral cutaneous nerve of the calf, a branch of the common peroneal nerve, supplies the skin on the upper part of the lateral surface of the leg. The superficial peroneal nerve, a branch of the common peroneal nerve, supplies the skin of the lower part of the anterolateral surface of the leg. The saphenous nerve, a branch of the femoral nerve, supplies the skin on the anteromedial surface of the leg. Dorsum of the foot is supplied by on the medial side of the foot up to the ball of the greater toe by the saphenous nerve. First cleft between great toe and second toe by deep peroneal nerve. On the lateral side of the foot and little toe by the sural nerve. The dorsum on distal phalanges of the toes by plantar nerves. Rest of the dorsum of foot, including medial side of great toe, from the ball is supplied by medial and intermediate cutaneous branches of superficial peroneal nerve. Superficial veins of the front of the leg and dorsum of foot are as follows. There are two dorsal digital veins in each toe. Each joins the corresponding vein of the adjacent toe to form a dorsal metatarsal vein. The dorsal metatarsal veins join the dorsal venous arch. The dorsal venous arch lies on the distal parts of the bodies of the metatarsals. It drains the dorsum of the foot and toes. The dorsal digital vein on the medial side of the big toe joins with the medial end of the arch to form the great saphenous vein and the dorsal digital vein on the lateral side of the little toe. Join the lateral end of the arch to form the small saphenous vein. The small saphenous vein runs posteriorly, passes first inferior to the lateral malleolus and then posterior to the lateral malleolus. It ascends to the popliteal fossa in the back of the leg and drains into popliteal vein. The great saphenous vein passes posteriorly on the medial side of the foot. It is the longest superficial vein in the body. It ascends anterior to the medial malleolus, then obliquely across the distal third of the medial side of the leg. In its course, it communicates with the deep veins piercing through the deep fascia. On the medial side of foot, it communicates with medial plantar veins. Anterior to the ankle, it communicates with anterior tibial veins. Behind the medial border of the tibia, it communicates with posterior tibial veins. The valves in the communicating veins permits blood flow only from superficial to deep veins and not vice versa. This needs to be remembered. Thereafter, it runs posterior to the knee joint and then enters the front of thigh and finally drains into the femoral vein. The greater part of the lymph from the skin and superficial fascia on the front of the leg drains upward and medially in vessels that follow the great saphenous vein to end in the vertical group of superficial inguinal lymph nodes. A small amount of lymph from the upper lateral part of the front of the leg may pass via vessels that accompany the small saphenous vein and drain into the popliteal nodes. The deep fascia of the leg is very strong and is called crural fascia. It surrounds the leg like a sleeve and is fused with the periosteum where the bones are subcutaneous. Thus, it is attached to the borders of these areas on the tibia, fibula and their malleoli, forming intermuscular septa and retinacula. The intermuscular septa separate various groups of muscles, give attachments to their fibers proximally and place each group within a tight fascial box. There are three named intermuscular partitions: interosseous membrane extending between the sharp interosseous borders of tibia and fibula, the anterior intermuscular septum and the posterior intermuscular septum, where one end of them is attached to the fibula. These three septa divide the leg into three compartments. Anterior compartment is present between the lateral surface of tibia and anterior intermuscular septum. The lateral compartment is present between the anterior and posterior intermuscular septa. The posterior compartment is present behind posterior intermuscular septum and tibia and is divided into three layers by anterior and posterior coronal sheets of fascia. Thus, when the muscles contract, they are compressed by the fascia so that blood is pumped upwards from them in the veins, which is a very important mechanism of venous return from the lower limb. Extensive division of the fascia or wasting of the muscles within the fascia impairs this venous return and leads to swelling of the limb because of accumulation of fluid called edema. At the ankle, the deep fascia forms thickened bands called retinacula, which holds the tendons close to the joint and prevent them from springing forwards in dorsiflexion of the ankle. There are two retinacula on the front of the ankle, superior and inferior extensor retinacula. On the lateral side, there are two, superior and inferior peroneal retinacula. One on the medial side of the ankle called the flexor retinaculum. We will discuss the extensor retinacula in this session. Superior extensor retinaculum is a broad band which extends between the triangular subcutaneous area of the fibula and the anterior border of the tibia. Inferior extensor retinaculum is Y-shaped. The stem of the Y is attached to anterior part of upper surface of the calcaneus, medial to the extensor digitorum brevis and in front of the interosseous talocalcaneal ligament. From the lateral end, a superficial part of it continues over the muscle to join inferior retinaculum. Medially, the limbs of the Y separate from each other. The superior limb or band is attached to the medial malleolus of tibia. the inferior limb or the band passes to the medial side of the foot and fuses with the fascia of the sole. The deep fibers of the retinaculum turn back on themselves, forming loops around the tendons. There are two loops, one around the extensor digitorum longus and peroneus tertius, and another around the extensor hallucis longus, and the anterior fibers extends on the tibialis anterior. Synovial sheaths of extensor tendons surrounds the three muscles separately in the anterior compartment. The sheath extending over the tibialis anterior extends from the upper border of the superior extensor retinaculum to the insertion of the tendon. The sheath extending over the extensor hallucis longus tendon begins between the superior and inferior extensor retinacula and reaches the proximal phalanx of the big toe. The sheath extending over the extensor digitorum longus and peroneus tertius extends from the lower part of superior extensor retinaculum to the middle of the dorsum of the foot. The contents of the anterior fascial compartment of the leg are: there are four muscles in the anterior compartment of the leg: tibialis anterior, which arises from tibia, extensor hallucis longus, extensor digitorum longus, and peroneus or fibularis tertius, which arises from the fibula. Collectively, they dorsiflex the foot at the ankle joint, extend the toes, and invert the foot. All the muscles are innervated by the deep fibular or peroneal nerve, which is a branch of the common fibular or peroneal nerve and supplied by the anterior tibial vessels. Tibialis anterior muscle is the most anterior and medial most of the muscles in the anterior compartment of the leg. It originates mainly from the upper half to 2/3 of the lateral surface of the shaft of the tibia and adjacent surface of the interosseous membrane. It also originates from overlying deep fascia. The muscle fibers of tibialis anterior converge in the lower 1/3 of the leg to form a tendon which descends deep to the retinacula and passes on the medial side of the foot and then onto the plantar surface. The tendon attaches to the medial and plantar surfaces of medial cuneiform and adjacent plantar surface of first metatarsal associated with the great toe. Tibialis anterior is innervated by the deep peroneal or fibular nerve. Tibialis anterior dorsiflexes the foot at the ankle joint and inverts the foot at the intertarsal joints when foot off the ground. During walking, it provides dynamic support for the medial arch of the foot by acting as a sling from above. That is, when the foot is on the ground, the muscle helps to balance the leg and talus on the other tarsal bones so that the leg is kept vertical even when walking on uneven ground. The extensor hallucis longus muscle takes origin from the middle 1/2 or 2/4 of the medial surface of the fibula and adjacent interosseous membrane. The fibers passes downwards and medially. In the lower half of the leg, the tendon of extensor hallucis longus appears between the tendons of tibialis anterior and extensor digitorum longus, passes deep to the extensor retinacula and descends into the foot. In its course, it crosses anteriorly across the distal part of the anterior tibial artery and deep peroneal nerve from lateral to medial side. Then, in the foot, it continues anteriorly on the medial side of the dorsal surface. The tendon splits into 3 slips. The central slip inserts to the dorsal surface of base of distal phalanx. The lateral slip attaches to deep transverse metatarsal ligament, and the medial part joins the tendon of the abductor hallucis and is attached to the proximal phalanx. Like all muscles in the anterior compartment of leg, the extensor hallucis longus muscle is innervated by the deep fibular nerve. Because it crosses anterior to the ankle joint, it dorsiflexes the foot at the ankle joint and extends the great toe. The extensor digitorum longus muscle is the most posterior and lateral of the muscles in the anterior compartment of leg. It originates mainly from the upper 1/2 to 3/4 of the medial surface of the fibula, lateral to and above the origin of the extensor hallucis longus muscle, and extends superiorly onto the lateral condyle of the tibia. Like the tibialis anterior muscle, it also originates from deep fascia covering it. The extensor digitorum longus muscle descends down to form a tendon which passes deep to the extensor retinacula and continues into the dorsal aspect of the foot. Here it divides into 4 tendons for the lateral foretoes. Near the metatarsophalangeal joint, each tendon joins with the tendons of the extensor digitorum brevis from the 2nd to 4th toes and forms dorsal digital expansion. Through dorsal digital expansions, it is inserted into the dorsal surfaces of the bases of the middle and distal phalanges of the lateral foretoes. It divides into 3 slips as in the extensor hallucis longus. The thick central slip continues on the dorsal surface of the proximal phalanx and gets inserted to the dorsal surface of base of the middle phalanx. The lateral slips and medial slips pass on the lateral and dorsal surfaces of the proximal interphalangeal joint, approach each other, gets inserted into dorsal surface of the base of the distal phalanx. The little toe has only the long extensor tendon, but the insertion is same as the other toes. It is innervated by the deep peroneal or fibular nerve. Extensor digitorum longus extends the toes and dorsiflexes the foot at the ankle joint. The peroneus tertius is also called as fibularis tertius muscle. It is normally considered part of the extensor digitorum longus. It originates from the lower 1/4 of medial surface of the fibula, immediately below the origin of the extensor digitorum longus muscle, and the 2 muscles are normally connected. The peroneus tertius descends into the foot with the tendon of extensor digitorum longus. On the dorsal aspect of the foot, it deviates laterally to insert into the dorsomedial surface of the base of the 5th metatarsal. It is innervated by the deep fibular nerve. Fibularis tertius assists in the dorsiflexion and eversion of the foot. Extensor digitorum brevis arises from the anterior part of the dorsal surface of the calcaneus and from the stem of the inferior extensor retinaculum. It forms 4 tendons for the medial foretoes. The most medial part forms the extensor hallucis brevis. Its tendon runs obliquely across the dorsum of the foot, joins with the tendon of extensor hallucis longus, and gets inserted to the base of the proximal phalanx of the big toe. The remaining lateral 3 tendons join the tendons of the extensor digitorum longus of the second to fourth toes and are inserted into the middle and terminal phalanges through dorsal digital expansion formed near the metatarsophalangeal joint. Please recall the insertion of extensor digitorum longus. Each dorsal digital expansion divides into 3 slips. The thick central slip continues on the dorsal surface of the proximal phalanx and gets inserted to the dorsal surface of the base of the proximal phalanx of great toe and middle phalanges of the second to fourth toes. The lateral slips and medial slips pass on the lateral and dorsal surfaces of the proximal interphalangeal joint, approach each other and gets inserted into dorsal surface of the base of the distal phalanx. The little toe has only the long extensor tendon, but the insertion is same as the other toes. It is supplied by deep peroneal nerve. Extensor hallucis brevis extends metatarsophalangeal joint of the big toe. The tendons of the second to fourth toes extend the interphalangeal and metatarsophalangeal joints of the respective toes. This is the summary of muscle attachments, nerve supply and its actions. Do make the chart like this, which will be helpful for revising during your exams. Note the following points. Extension or dorsiflexion of ankle is the movement of the foot away from the ground. The peroneus tertius muscle extends the foot at the ankle joint along with the other muscles in this compartment and is supplied by the deep peroneal nerve. The muscle also everts the foot at the subtalar and transverse tarsal joints along with the peroneus longus and brevis muscles, but receives no innervation from the superficial peroneal nerve. The extensor digitorum longus tendons on the dorsal surface of each toe become incorporated into a fascial expansion called the extensor expansion. The central part of the expansion is inserted into the base of the middle phalanx and the lateral two parts converge to be inserted into the base of the distal phalanx. Coming to the neurovascular bundle. The anterior tibial artery is the smaller terminal branch originating from the popliteal artery in the posterior compartment of leg. It arises at the level of the lower border of the popliteus muscle and passes forward into the anterior compartment of the leg through an opening in the upper part of the interosseous membrane close to the neck of the fibula. The anterior tibial artery descends through the anterior compartment on the interosseous membrane accompanied by the deep peroneal nerve. In the upper part of its course, it lies deep beneath the muscles of the compartment. In the lower part of its course, it lies superficial in front of the lower end of the tibia. In the distal leg, it passes behind the superior extensor retinaculum, lies between the tendons of extensor hallucis longus on its medial side and the deep peroneal nerve and the tendons of extensor digitorum longus on its lateral side. Here, the pulsations can easily be felt in the living. It leaves the leg by passing anterior to the distal end of the tibia and ankle joint and continues on to the dorsal aspect of the foot as the dorsalis pedis artery. The anterior tibial artery gives off the following branches. In the proximal leg, it gives off anterior tibial recurrent branch, which connects with the anastomotic network of vessels around the knee joint. Along its course, the anterior tibial artery supplies numerous branches to adjacent muscles. Below, it anastomoses with the perforating branch of the fibular or peroneal artery, which passes forward through the lower aspect of the interosseous membrane from the posterior compartment of leg. Distally, the anterior tibial artery gives rise to anterior medial malleolar artery and an anterior lateral malleolar artery, which pass posteriorly around the distal ends of the tibia and fibula respectively and connect with branches from the posterior tibial and fibular arteries to form an anastomotic network around the ankle joint. It continues below on the dorsum of foot as the dorsalis pedis artery. The dorsalis pedis artery, the continuation of the anterior tibial artery, begins on the anterior surface of the ankle joint and runs with the deep peroneal nerve, deep to the inferior extensor retinaculum and extensor hallucis brevis, to the proximal end of the first intermetatarsal space, dips into the sole and terminates by anastomosing with lateral plantar artery. Near the base of the second metatarsal bone, it gives off the arcuate artery, and just before dipping into the sole, it gives the first dorsal metatarsal artery. On the dorsum of the foot, it lies on the tarsal bones and is readily palpated against them between the tendons of extensor hallucis longus and extensor digitorum longus. Near the ankle joint, it gives off medial and lateral tarsal branches to the tarsal bones and extensor digitorum brevis. The arcuate artery runs laterally across the bases of the metatarsal, deep to the extensor tendons, and terminates by anastomosing with lateral malleolar network. It gives a dorsal metatarsal artery to each of the intermetatarsal spaces. Each dorsal metatarsal artery runs forwards over the corresponding dorsal interosseous muscle and divides into two dorsal digital arteries for each of the two adjacent toes. Along the course, each artery communicates with plantar arch and plantar metatarsal arteries in the sole of the foot through the proximal and distal perforating branches respectively. The first and last of these dorsal metatarsal arteries sends a branch to the medial side of the big toe and the lateral side of the little toe respectively. Coming to the venous drainage of the front of leg, deep veins follow the arteries and have similar names. These tributaries drain into the venae committantes of the anterior tibial artery. Venae committantes of the anterior tibial artery join venae committantes of the posterior tibial artery in the popliteal fossa to form the popliteal vein. The nerve associated with the anterior compartment of the leg is the deep fibular nerve, or the nerve of the compartment is the deep peroneal nerve. The deep peroneal nerve is one of the terminal branches of the common peroneal nerve. In the substance of the peroneus longus, on the lateral side of the neck of the fibula, the common peroneal nerve divides into superficial peroneal nerve and deep peroneal nerve. The deep peroneal nerve passes anteromedially, piercing the anterior intermuscular septum that separates the lateral from the anterior compartments of leg, reaches the anterior surface of the interosseous membrane, passing deep to the extensor digitorum longus. On the interosseous membrane, it meets and descends with the anterior tibial artery. In its course, the deep peroneal nerve first lies lateral and then anterior and finally lateral to the anterior tibial artery. Because of this course, it is called nervi essitans. Near the distal end of the leg, it passes behind the extensor retinacula and continues into dorsal aspect of foot. The deep peroneal nerve in the leg supplies all the muscles in the anterior compartment, tibialis anterior, extensor hallucis longus, extensor digitorum longus, and fibularis tertius. It gives off articular branch to the ankle joint. In the dorsal aspect of the foot, it divides into lateral and medial terminal branches. The lateral terminal branch forms pseudoganglion deep to the extensor digitorum brevis, and through it supplies the muscles extensor digitorum brevis and second dorsal interosseous and tarsal and metatarsophalangeal joints of the middle three toes. The medial terminal branch supplies the first dorsal interosseous muscle, first metatarsophalangeal joint, and the skin between the great and second toes. The following are the clinical aspects of the anterior compartment of leg. The anterior compartment syndrome or the anterior compartment of the leg syndrome is produced by an increase in the intracompartmental pressure that results from an increased production of tissue fluid. Soft tissue injury associated with bone fractures is a common cause, and early diagnosis is critical. The symptoms include the following. The deep aching pain that is characteristic of this syndrome can become severe. Dorsiflexion and plantar flexion of the foot at the ankle joint increases the severity of the pain. As the pressure rises, the venous return is diminished, thus producing a further rise in the pressure. In severe cases, the arterial supply is eventually cut off by compression and dorsalis pedis arterial pulse disappears. The deep peroneal nerve in the compartment will be compressed, and due to this, the tibialis anterior, the extensor digitorum longus, and the extensor hallucis longus muscles are paralyzed. There is loss of sensation in the area supplied by the deep peroneal nerve, that is, the skin cleft between the first and second toes. The anterior compartment of the leg can be decompressed and relieved from the symptoms by making a longitudinal incision through the deep fascia, which will prevent from anoxic necrosis of the muscles. Foot drop is the inability to lift the forefoot. This is due to the paralysis of weakness of dorsiflexors of the foot. In the normal leg, the ankle and foot dorsiflexors, which are the tibialis anterior, extensor digitorum longus, and extensor hallucis longus, helps clear the foot during the swing phase of walking and control plantar flexion of the foot on heel strike. But in the affected leg, the forefoot will be dragged on the ground due to the paralysis of the dorsiflexors. So foot drop can hinder walking and increase the risk of tripping and falling. The mechanism of injury can be due to the following. Direct nerve injury to sciatic nerve or common peroneal nerve or deep peroneal nerve. This can be due to compression disorder like the anterior compartment of leg syndrome or fracture or dislocation. Injury to the nerve roots in the spine may also cause foot drop. Neurological disorders like stroke, multiple sclerosis, cerebral palsy, Charcot-Marie-Tooth disease can also cause foot drop. Muscle disorders that cause the muscles to progressively weaken or deteriorate may cause foot drop. These include muscular dystrophy, amyotrophic lateral sclerosis, which is also called as Lou Gehrig's disease, and polio. Thank you for your patient listening. If you have not yet subscribed, please do subscribe to the channel and hit the bell notification. If you like the channel, share it with your contacts and friends.